Thanks for joining us again, and welcome to the Senior Report. I'm your host, Jorge Cruz, and today we're visiting Associated Orthopedics of Union, New Jersey. With the fall and winter season upon us, we decided to visit the Associated Orthopedics of Union, New Jersey. I like to call this season the slip and fall season. Joining me today is Dr. Kristen Cardamone, physiatrist for Associated Orthopedics. Dr. Kristen Cardamone is an interventional physiatrist who completed her residency training through New York Presbyterian, University Hospital of Columbia, and Cornell, followed by fellowship training in sports medicine and orthopedic spine rehabilitation through New York Beth Israel Medical Center. Welcome to the Senior Report, Dr. Cardamone.
Thank you, it's nice to be here.
Dr. Cardamone, can you tell our viewers what a physiatrist is and what role do you play in Associated Orthopedics?
Sure. One of the most common questions that I get. Physiatrist sometimes can be mistaken for a psychiatrist or a podiatrist. I've heard them both. Physiatrist, a specialist who specializes in physical medicine and rehabilitation. It's a specialty that basically was in its early years in the 1930s came about, more formalized as a specialty in 1947 after World War II. Basically my role, or what physiatrist is I specialize in optimizing function in a non-operative conservative way. In my role in Associated Orthopedics, basically I'm a musculoskeletal specialist. So for those viewers who might not know what musculoskeletal means, it's a big mouthful, it's a big word. Basically that has to do with anything having to do with muscles, joints, nerve, and bone. So I specialize in that, and I basically handle that in any non-operative measures such as injections, prescribing physical therapy, which I basically would design the programs specifically to cater to each person's unique injury or needs. Other types of, whether it be joint injections such as knee injections, shoulder injections, back or neck injections, those things can be all performed in a more of a conservative way. So my role is to try every option possible so that you can avoid surgery if reasonable, or if you did have to have surgery, to help guide you through that process, whether it be through pain management or rehabilitating you, whether it be through injections or therapy. So that's a main nuts and bolts of what a physiatrist is. We overlap with orthopedics, neurology, and internal medicine, so my role kind of combines several of those different types of specialties.
Very good. As the physiatrist, can you explain what makes your approach to pain and injuries unique to most other pain management physicians?
Sure. In addition to kind of my traditional training that I had during residency, and most of us are taught during residency in medical school, such would be pain medications, prescribing physical therapy, and whatnot. I look at the patient as a whole. So I address patients' full needs, including how they're sleeping, their stress levels, their nutritional needs, their activity, and also their pain. And I basically make a management program so that I combine all of those components. You can't unfortunately just treat someone's back pain if they've had chronic back pain for years and aren't sleeping well, and also unfortunately might have anxiety disorders. So all of that must be treated together. In addition to some of the traditional treatments such as steroid injections, I do homeopathic type injections for joints and tendon and muscle. So very few side effects, and they're great for some of the seniors actually specifically who may be suffering from diabetes and who can't really have a lot of steroid injections. So it's very nice because then the sugars wouldn't be increased, which I know is a big concern with a lot of the patients. And also if they're on Coumadin, there's also a lot of concern and risks with taking a lot of anti-inflammatories. So instead of doing a lot of anti-inflammatory type medications, homeopathics or nutritional supplements which have anti-inflammatory effects are great options, as well as addressing their diet. Having more of an anti-inflammatory type diet can also help a great deal. So I do that, and in addition to that, platelet-rich plasma is an option that we can do for someone who has maybe more of a chronic type injury which isn't resolving with some of the traditional approaches such as steroid injections, or if they're not a candidate for surgery. That's some other options, to name just a few.
Thank you, Doctor. The slip and fall season is upon us, and I thought we should seek the expert advice from the group to discuss the type of injuries that you see this time of year. Doctor, can you tell our seniors how can we prevent these injuries?
Sure. Some of the injuries may just come from bad luck from time to time, for sure, but many of them can be prevented. One of the main ones, especially as the colder weather is approaching, is the rain and the ice issue. I see a lot of patients who will come in, like you said, with a slip and fall because of ice. Everyone likes to run out and get the mail in the morning or get out as fast as they can. Unfortunately, that's the worst time of day to go out. That's when it's probably the iciest. The sun hasn't gotten a chance to really hit the pavement much, and a lot of slip and falls do occur in the morning, and can result in, it could be minor or it could be as serious as hip fractures or wrist fractures from falling. So I do advise people not, especially when it's icy or a little bit wet, maybe wait till a little bit later morning or early afternoon if they were to kind of go out if it wasn't necessary. Another major issue I see are basically throw rugs. And those can be any time of year, but especially maybe in the winter, they're running around with their warmer slippers on and they have throw rugs around the house, and the foot just gets caught and there's a fall right there, which again could be a wrist fracture or a hip fracture or just back pain maybe. And that can go for even some rugs even outside on the doorstep. So we want to minimize and make the inside and the outside very safe. Other things are shoveling. Obviously, the snow is hopefully not going to be too bad this year, but every winter we do have a lot of back injuries from shoveling. And people want to get outside and stay active, and we certainly want them to remain active. But doing too much shoveling over too long of a period of time, especially if you have a weak back, would be not advisable. So if you can get someone to help you, you shovel for a little bit, you take some breaks. If you do have severe back pain that you know about or an existing back condition, maybe reaching out to a local community, seeing if there's any kids in the neighborhood who can help you to shovel, or if your community offers anything like that for seniors. I would definitely advise that, because back pain is certainly going to be flared with the shoveling. And that also would then, taking in mind any cardiac conditions, you want to be careful about that. So I wouldn't really advise doing a lot of shoveling. There always is a kid around the neighborhood who's happy to help out, and can help out in your neighborhood, which would be great. And then as far as other injuries that we see, a lot of them are usually from tripping over something or from even being weak. A lot of people have balance issues and don't really recognize it. And most of the year maybe they can get by when the surfaces are dry. But if they have a little bit of weakness in their legs because they're not as active as they would like to be, or maybe they had an injury earlier that year or a surgery, certainly wanting to make sure the balance is up to par and that their strength is good in the lower extremities. So certainly if they are concerned, or you even noticed subtle balance issues, to seek a physiatrist, like myself, to do a full evaluation, make sure your balance is where it should be, and if there's different things that we can do, we could certainly design the program accordingly for balance or for strength, and that would put you in better shape for the oncoming winter season, to avoid hopefully some of the slip and falls and some of the balance issues.
Do you provide those evaluations here,
Yes.
balance testing?
We don't do balance testing on site per se. That would be done more in a physical therapist office, which I would design the program accordingly if I did see on my exam that there were balance issues, and some tests that I would do. And I would do strength testing if I saw that there was some weakness in the hips, for example, which are a main issue. If the hips are weak or the knees are weak, there's going to be a lot of give way or locking. So I would see that on my exam, and then I could design a program accordingly. So the therapist would know to work on either balance or lower extremity strengthening. Or I have seniors who come in without any device such as a cane, and they really might be in need of using that. And something as simple as adding on a simple type of cane, or with whether it be a single cane or which have prongs on it, which might be a little bit more stable, or if they had to advance to a walker, we would be able to assess that on my exam, and then the physical therapist could trial some of these different devices too. And something as simple as that actually helps a lot with balance. So that's one thing that we would do.
So can a family member bring in grandma, let's say, and we want to prepare her for the winter
Sure.
season. We're concerned about an injury she had a couple of months ago.
Sure.
Her legs are a little weak. Would you be able to do a complete assessment
Sure.
and make recommendations?
Sure, absolutely. We'd see where they were, we take their history, we take a thorough history and see if they had any pre-existing injuries like you said, or any prior surgeries, which might be predisposing them to further injury, or we just do a simple evaluation if they haven't had anything previously. We'll be able to kind of just see where they're at and make some suggestions and advice and go over some education issues for them for the upcoming season and make some recommendations if they did have pain issues or strength issues. And if we needed to prescribe physical therapy or further imaging or other procedures, we could do that at that time. And it's also just as important for the caregiver. Sometimes, certainly if a mother, father, or having some difficulty walking, the children oftentimes are very much involved in their care, and they also can suffer back injury. So I actually like that the caregiver would come in with the patient so that we can talk to them together and see how the caregiver could also avoid having some injuries and properly help out the patient so that no one has an injury.
Our viewers, the bulk of our viewers, I would say, are seniors and their caregivers. Of course, there's a younger group in Linden as well,
Sure.
and I know that you see a lot of athletes in here.
Yes.
What can an athlete do to prepare for a season, and can you see them pre-injury as well?
Yes. I like to call it prehab. So there's options of prehab and then there's posthab. So prehab would be hopefully kind of just assessing pre-season or hopefully pre-injury to prevent it, to assess for any muscle imbalances or any weaknesses. Again, evaluate if they had any pre-existing injury beforehand that we would want to look at a little bit more closely. Obviously, strength issues are also huge for them. If there's, like I said, muscle imbalances, we would be able to evaluate that and give them and also their trainer recommendations for the season. A lot of times we want to avoid, especially with some of more of the high school and college athletes, you have to be careful as far as injections during the season because steroids are not something that you can give during the season with the WADA rules and NCAA rules. So we would work with them to determine if something is warranted pre-season or can wait till postseason. So that's also a big discussion that we have if someone did have, needing injections. So we certainly can talk about all that.
Well, thank you, Dr. Cardamone. I appreciate the information, and our viewers will take this information and hopefully share it with their caregivers. The caregivers can share it with the people that they're taking care of, and that's what the show is all about. We want to try to keep our seniors and their caregivers informed of the services that are out in the community, and we're very excited to be at Associated Orthopedics, and we'd like to next speak to Dr. Facone, an orthopedic surgeon, and that's coming up. And we're back. Joining us is Dr. John Facone, an orthopedic surgeon for Associated Orthopedics, who completed residency training through the University of Medicine and Dentistry of New Jersey, followed by fellowship training in orthopedic sports medicine at Temple University Hospital in Philadelphia. Welcome to the Senior Report.
Hi,
Dr.
how are you?
Facone. Very well, thank you. We heard of the type of injuries you see this time of the year, so as an orthopedic surgeon, what are the interventions for knee, hip, and sports injuries?
Well, we do tend to see a lot of lower extremity injuries, unfortunately, as the weather gets colder and the surfaces get more slick. People unsuspectingly and unfortunately sustain lower extremity injuries fairly frequently. One of the most common injuries we see is known as the hip fracture, which in and of itself is a misnomer. You don't really break the hip, which is actually a joint. You fracture, as we say technically in medicine, the bones around a joint. So when people say they have a hip fracture, they technically sustained a proximal or top part of the femur fracture. This is a femur bone, and the ball of the ball and socket joint would be part of the hip, followed by the neck of the femur, and then the shaft of the femur. And we do see a lot of hip fractures in the elderly or senior folks with the slip and fall season upon us. Sometimes those fractures are fixated with plate and screws, just like actually our model here has a plate and screws across it. Sometimes with a rod that is inserted directly in the bone and stabilized with screws. And sometimes the neck of the femur, when it's broken, needs to be stabilized either with screws itself or sometimes undergo a partial hip replacement, which is probably the most significant of the types of fractures, requiring the largest of the surgeries.
The hip replacement and hip fracture, as they call it, is could be devastating for someone in their 70s and 80s.
Sure, they can be. They're very common, and unfortunately, they pretty much all across the board require surgical intervention. The non-operative management for those fractures would consist of traction for a prolonged period of time, sometimes up to months. And that has complications like bed sores and blood clots and pulmonary or breathing issues, which can really debilitate a person even further. We see a lot of other lower extremity injuries, the knee, the ankle. Those of the knee sometimes are fractures also of the bone of the thigh bone known as the femur, or the top known as the tibia. Many times those fractures can be treated non-operatively if they are, as we say, non-displaced, meaning on an x-ray they won't show any real change in the anatomy or alignment of the bone. If they do get some displacement, they sometimes are fixated with plates and screws, as we mentioned before, sometimes a rod. Seniors are at risk, though, to get some of the injuries that we see in younger athletic people, tearing a ligament, tearing a cartilage in the knee. We try to manage those non-operatively in that patient population, but they do occur. There are also, though, risks for the tendinous tears around the knee, around the kneecap as it's called, or patella as we would say. The quadriceps tendon runs to the top of the kneecap, while the patellar tendon runs from the bottom of the kneecap. And if those tendons are ruptured or torn from a slip and fall, they require surgical intervention to reattach the tendon to the kneecap or to the patella.
What is a typical hospital stay, length of stay for a hip replacement?
We try to have the people only in the hospital for about 3 days at its maximum. Patient will come into the emergency department, hopefully have surgery within 24 hours or so, and then about 2 or 3 days afterwards try to get them to the next phase of healing, which usually after lower extremity fractures in the senior population would be a referral to a subacute or short stay rehab facility. Those facilities are nicer to go to than trying to go home. People would like to try to go home with family, but it's a lot more beneficial for the patient and the family for them to have an opportunity to go to an inpatient rehab facility where the therapy is more aggressive and it's much more frequent. We can help you negotiate stairs a little bit better. If the person needs an assistive device like a cane or a walker, they get a little bit more instruction in its use.
Well, I do want to ask you more about what happens after surgery, but going down the leg a little bit more to the knee, what are the most common type of knee injuries that you see with seniors and younger people as well?
I'd probably say the most common type of knee injury we're going to see in this particular population, as we discussed, the seniors, would be what's called a tibial plateau fracture. The tibia is the top part of the knee known as the shin bone. The tibial plateau would be the top part of the tibia closest to the knee. And that is the structure probably most commonly injured that we see in this population, because it can become injured from a twisting mechanism where the ligaments on the side or inside will pull on it to cause the fracture, or from an impaction injury when the lower part of the femur or thigh bone is driven directly into the top of the tibia or shin bone. Many times, though, those fractures are not displaced, and we can manage those with a brace and period of non-weight bearing, and then manage them non-operatively. Sometimes they'll require additional imaging, so not just an x-ray but a CAT scan to really gauge the amount of displacement, or an MRI to look at concomitant ligamentous or cartilaginous injuries. We do also, as we're talking about the tibia, commonly see many ankle injuries. Slips and falls do result in numerous ankle fractures and ankle fracture dislocations, which would be a break around the ankle with a dislocation of the joint. Those also can be devastating in the senior population, where you might find osteoporosis. One of the weakest part of the skeleton is the lower part of the tibia or lower part of the shin bone just above the ankle. So those are often treated with surgical intervention, because many times those fractures are not displaced. And one thing about fractures in general in orthopedics is those injuries that occur around a joint, we like to have those stabilized as anatomically as possible, so the bones can provide as rigid a support system for the joint. And when you fracture the bones near the ankle, that is paramount to the ankle stability.
How can our seniors or younger people prepare for this season? So
I think one of the biggest
to avoid
things,
the injuries.
one of the biggest things I tell people in general, and maybe it's from a sports medicine background, is try to stay as flexible as possible. So if you can have an exercise regimen that allows you to stay mobile and as agile as possible, you can prevent many injuries or minimize the result of the injury. And I liken it to if you see people that are trying to ice skate and they're fairly rigid and fairly tense, and when they fall, they are afraid to fall. Whereas if you are a little more flexible, you're more apt to be able to absorb the impact and prevent a significant injury.
Very good. Okay, getting back to the hospital stay and after a hip or a knee replacement. The average length of stay in the hospital is about 3 days,
Right.
unless there's complications, of course. What is the follow-up to surgery, Dr. Falcone? What happens after a short stay at the hospital?
So after you're in the hospital for those 3 days or so, as we just said, subacute rehab usually follows. I usually tell patients that you'll be in that subacute rehab facility anywhere from a few days to like 10 days. So maybe time out of your home would be from a week to about 2 weeks or so. At the subacute rehab, as we've mentioned already, people are able to get therapy several times a day, help with stairs, help with assistive devices like crutches, cane, walker, things. Once you are able to be discharged from there, then we'll see you back here in our office, at which point in time we usually arrange more physical therapy on an outpatient basis. Sometimes Dr. Cardamone can help us supervise that rehab protocol with her training, and many times it just goes simply to the physical therapist. If there are large surgical wounds or complicated surgical wounds, sometimes a visiting nurse can be arranged either to help with wound care or to help around the home as it is.
I know that with the length of stay decreasing in the hospitals as insurance companies want,
Sure.
The length of stay in subacute rehab units have increased.
Mm-hmm.
And the length of stay you just mentioned, I think, is for a younger person that's not compromised.
Right.
And I've noticed that the length of stay for seniors can be anywhere from 2 weeks to 4 weeks, depending on the type of injury
Sure.
and how compromised they are. I think the subacute units have kind of taken on the role of the med-surg units, where typically for a hip fracture you would stay in the past a couple of weeks in the hospital.
Right.
And that's gone down to 3 days.
Sure.
So the subacute units have kind of increased their length of stay as well. I've had
Certainly.
conversations with some of the physical therapy directors at some of the local subacute rehab units. So you fractured your hip, you're admitted to the hospital, you've had your surgery, you've had your 3-day stay at the hospital, and prepare, if you can, for a short stay at a subacute rehab unit where you will see an interdisciplinary team that consists of the doctor, a physician, a physiatrist, the physical therapy team, a social worker, and nurses to care for you. The nursing care is usually 24 hours a day, 7 days a week. And after a stay of, let's say, anywhere between 2 and 4 weeks, you'll be referred to a visiting nurse service where they will continue their evaluation, and you can possibly receive physical occupational therapy and maybe some a home health aid to help you around the house, and that's temporary. Of course, it depends on the type of insurance that you have. So that expect that after a stay in the hospital. Can you tell me more about associated orthopedics practice and the type of testing that you perform in your practice?
Well, we primarily testing, I think we would talk about from an orthopedic standpoint, would be x-rays. We do have a digital x-ray unit here. Those are enhanced images that we have an ability to manipulate on the computer for better visualization and more accurate thought or decision-making process in terms of sizing of plates or screws or length of a rod, or when we get into joint replacements and the size and shape of the prosthesis. We are able to then see those images even from home
So can I know that some of the doctors at the hospital can access it through an iPad or even a cell phone. Is that right?
Yes.
Times have changed. No more.
We do have those abilities.
No more wet readings.
No, we do still have a light box here on premises, just because we do still see older fashioned x-rays, but certainly much more commonly digital x-rays are now available.
Are they much more detailed than the older?
They are. It's also the computer ability, so that even if an x-ray is not an ideal degree of darkness or lightness, the images can be manipulated.
Very good. And I've noticed that you can expand.
Exactly.
Just like
Zoom
we do
in
on,
or zoom
on
out.
an iPhone,
Exactly.
which is great. Good to get the detail. The office location for your group is very convenient to Overlook Hospital,
Yes.
which you are affiliated with.
Yes, that's our home hospital affiliation.
Can you,
1000 Galloping Hill Road is the address here at the office.
okay.
It's a pretty convenient trip to Overlook Hospital to and from for us.
So if a patient is from the Union area or from the Linden area, comes in, they think they may have fractured something, they come to you, they can come to the emergency room?
Exactly. It's worked out very well with our new office location here. They can come directly to the emergency room here at this 1000 Galloping Hill address. It's part of Atlantic Healthcare, which is Overlook's hospital system, and we can access the films very readily, make decisions, and then have the people transferred directly from the emergency department by ambulance to the main hospital in Summit.
Very
And
good.
provide definitive management there.
You'll follow the patient there
Exactly,
as well,
exactly.
all the way through. And sometimes pre-surgery, surgery, and post.
Exactly.
Very good. Well, the office seems very spacious, and I was wondering if you might want to give us a tour.
Certainly.
Very good. Well, that's what's up next. We'll tour the Associate Orthopedics Suite.
Welcome to our new office. This is our waiting room. This is an example of one of our waiting rooms. In here we have our ultrasound machine, which we use for injection guidance procedures, such as for joint injections or tendon injections. This is another one of our exam rooms, and in here we have our EMG machine, which we use for nerve testing for such diagnoses as carpal tunnel syndrome or pinched nerves in the neck or sciatica. This is our physician viewing room, where we do dictations and we're able to instantaneously retrieve digital x-ray. This is our x-ray room. We're able to have patients obtain x-rays on the day of the visit, and we're able to remotely access the pictures, view them, and also instantaneously review them. This is our centrifuge that we use for PRP, otherwise known as platelet-rich plasma. This is another option, elective procedure that can be done for tendon injuries or muscle injuries. We can perform laboratory testing right on site in the office the same day as patient visit.
But I just present before I'm back.
It's excellent. It's excellent. You both did great. And,
It's really been on camera before.
yeah,
Get that
and
nervous about it.